presiding. Please be seated.
Ready for our jury? All right, Ms. Smalls, go get our jury. Good afternoon, ladies and gentlemen. Was everybody able to follow my instructions and admonitions over the break?
Yes, sir.
All right. Mr. Knippen, Ms. Kraft, next witness.
Your Honor, the state will call Dr. Kim Brady.
Raise your right hand for me. You solemnly swear or affirm that the testimony you give in these proceedings will be the truth, the whole truth, and nothing but the truth, so help you God?
I do.
You can see that. Speak loudly into this microphone.
Ms. Kraft, you may proceed.
Thank you, Your Honor. Dr. Brady, can you please state your full name for the record, spelling your last?
William Kim Brady, B-R-A-D-Y.
And doctor, what is your current occupation?
I'm a physician.
And do you have a particular area of specialty?
Yes, I'm a maternal fetal medicine specialist.
And will you please explain to the ladies and gentlemen of the jury what a maternal fetal medicine specialist is?
In the field of obstetrics and gynecology, there are 4 subspecialties. One is urogynecology, the other is GYN oncology, infertility, and maternal fetal medicine. And what my specialty entails is basically taking a pregnant mom that has any medical disorder and add pregnancy to it, from diabetes to cancer, thyroid disease, you name it. And then also, in terms of the fetal aspect of things, we do perinatal ultrasound where we make diagnosis of fetal abnormalities. We do fetal therapy and fetal surgery.
Thank you, doctor. Are you currently employed?
Yes, I am.
And with whom?
I'm currently employed with TriHealth,
And what is your business address?
375 Dick Smith Avenue, Cincinnati, Ohio, 45220,
And how long have you been so employed, doctor?
since 1991.
In addition to your role as a maternal fetal medicine specialist with Tri-State, do you have any other duties and responsibilities as they relate to your position?
Yes, I'm the Director of Obstetrics at Good Samaritan Hospital. I also have appointments at Bethesda North Hospital, St. Elizabeth Hospital, Children's Hospital, Mercy Hospital, and the Christ Hospital.
Thank you, doctor. Can you please tell the ladies and gentlemen of the jury of your education and medical training that qualify you for your current positions?
Well, for undergraduate school, I went to the United States Military Academy at West Point. Then I went to Baylor College of Medicine in Houston, Texas, and got my Doctor of Medicine degree. I did my residency in obstetrics and gynecology in Denver, Colorado, and at the time it was Fitzsimmons Army Medical Center, following which I served in the military, doing 3 years of general obstetrics and gynecology, followed by a fellowship in maternal fetal medicine in Washington State.
Thank you, doctor. Are you currently licensed?
Yes, I am.
In which states?
Ohio, Kentucky, Texas, Colorado, and Washington.
And how long have you held your licensure in the state of Ohio?
Since 1991.
Do you hold any board certifications, doctor?
Yes.
And in what areas?
I'm board certified in obstetrics and gynecology, as well as board certified in maternal fetal medicine.
Doctor, are you ever invited to present or give lectures in areas that are relevant to your specialty?
Yes, I've lectured at our district meetings for the American College of Obstetricians and Gynecologists, as well as at our Society for Maternal Fetal Medicine, as well as the local OBGYN Society here in Cincinnati.
And have you ever published in any books or magazines or journals or any articles in areas relevant to your specialty?
Yes, I have published a multitude of publications, not only in American College, American Journal of Obstetricians and Gynecology, as well as what we call the Green Journal. And I also published a couple of chapters in Advances in Obstetrics and Gynecology.
Thank you, Doctor. Are you a member of any professional organizations?
Yes,
And can you please identify those that are relevant to your area of specialty?
well, I'm a member of the American Medical Association, member of the American Institute of Ultrasound and Medicine. I'm a member of a Society for Maternal Fetal Medicine and the American College of Surgeons.
Thank you, Doctor. I'd like to talk to you for a moment about your clinical duties and ask your best estimate on how many pregnant females do you treat in a given year?
Probably involved with 1 to 2,000 pregnant women from interpreting their ultrasounds to providing direct obstetrical care and/or consultation of high-risk pregnancies.
And Doctor, I know that you have explained to us what maternal fetal medicine entails, but of those 1 to 2,000 pregnancies that you are involved with in any given year, how many of those are high risk?
Probably 75%. It's because we're a referral center, so a lot of the general obstetricians, gynecologists refer to us because of findings on ultrasound that are abnormal, or findings that they see they don't understand, or they desire consultation because of mom's condition.
Thank you, Doctor. Approximately how many babies have you delivered over the course of your career?
It's a tough estimate. I can tell you that I'm in a group of 8 and we do 500 deliveries a year, at least primary care, not excluding consultation. So of those, I do at least 45 currently a year.
Okay.
But when I came to Good Sam at 91, I was the only specialty. So I was on 24 hours a day, 7 days a week, 365 for a couple years. So back then I was doing a lot more deliveries.
Thank you, Doctor. Have you had occasion to testify as an expert in the area of maternal fetal medicine before?
Yes,
And when you testified, was your opinion accepted as expert?
yes.
And when you've testified, has it primarily been for the state or for the defense?
Been more for the, it's been almost always for the defense.
Thank you, Doctor. Your Honor, may I approach?
You may.
Doctor, I'm showing you what's been marked as State's Exhibit 114 for purposes of identification. Do you recognize that document?
Yes,
Is that your curriculum vitae?
yes it is.
And does that document include all of your education, training, and employment, as well as the work that you have done throughout the course of your career in the field of maternal fetal medicine?
Yes.
Your Honor, at this time, the state would offer Dr. Kim Brady as an expert in the area of maternal fetal medicine.
The inquiry from the defense. You may proceed.
Thank you. Doctor, I'd like to start out by talking to you about the topic of intrauterine growth restriction, which is commonly abbreviated IUGR. Can you tell us what it is?
Well, intrauterine growth restriction is when a fetus is not growing commensurate with gestational age. In other words, it's lagging the normal fetal growth curve.
And what is the main symptom for a child that is diagnosed with intrauterine growth restriction or fetus?
Would you repeat the question, please?
What is the main symptom? What is the first obvious thing that you see with a fetus that has intrauterine growth restriction?
Well, the baby is small, as we call it, small for its gestation. On ultrasound, it's manifested. Generally, the first signs we see is a small abdomen, because babies are like us, or adults. We lose weight in our abdomens and put on weight. And so that's one of the first signs we see of a baby that's lagging in growth on ultrasound.
When we talk about lagging in growth, and we're all familiar with growth charts that we have both during pregnancy and after, when children are born, we watch them as they grow according to the growth chart. When we're talking about babies or fetuses that are diagnosed with intrauterine growth restriction, what percentiles are we commonly talking about? What are their approximate weights?
Most commonly, they're below the 10th percentile, and that's how IUGR is defined.
Below the 10th percentile?
For gestational age, yes.
And to put that in some numbers for us, when a child is born, what types of weights or how many pounds are we typically speaking of when we talk about below the 10th percentile?
In general, at term, any baby born that weighs less than 2,500 grams is considered it's considered a small for gestational age baby, which may consist of a growth restricted baby that is basically failure to thrive in utero, or you can also have just a small baby due to genetic or constitutionally small.
Okay. We're going to back up for just a second because a lot of us in this room don't have calculators and we don't necessarily think the way doctors do. So when you say 2,500 grams, what are we talking about in terms of pounds?
We're talking less than 6 pounds.
Less than 6 pounds?
Roughly.
And you said something else. You said just because you have a baby that's less than 6 pounds, that's not automatically diagnostic of intrauterine growth restriction?
No.
What did you mean when you said that sometimes you just have a genetically small child based on their genetics?
Well, if you just picture a kindergarten class, you have children of all different sizes, but basically the same age. And doesn't mean they're growth restricted. It just means that they're small. And then when you look at their parents, they're small. So it's basically, we call it constitutionally small, but not necessarily growth restricted. They were just genetically destined to be small.
And so when you say genetically destined, and you're looking at a constitutionally small baby, would you in fact look at the size of their parents?
Yes.
And if you have a smaller than average mother, could that play into the size of the baby?
It could.
Doctor, how do you go about diagnosing intrauterine growth restriction?
Most commonly, we do an ultrasound, and there are various biometric parameters we look at, and we measure the baby's head, not only the diameter in the skull, but the circumference. We then look at the fetal abdominal circumference, and then we also measure the baby's femur, and we have various software programs built into our ultrasound machines and reporting systems, and it'll calculate what the estimated fetal weight is. And based on that fetal weight of charts that have been through investigators arrive at what's appropriate for a certain gestational age, it will calculate a percentile for that baby. And if it comes up less than the 10th percentile, then we have a baby that's most likely IUGR.
Why do you take so many measurements?
Because you, just as you have tall adults, you can have tall babies, so the femur can be longer, but the rest of the baby could be smaller. So just investigations are showing that the single most sensitive parameter, what we measure, is the abdominal circumference. It's one of the first things that will fall off the curve in a baby that's developing IUGR.
Can you make a diagnosis? I mean, you've listed approximately 5 different measurements, correct?
Yes.
And that's when you're doing it by way of an ultrasound.
Correct.
Can you make a diagnosis of IUGR or intrauterine growth restriction off of just one ultrasound measurement?
No.
And is that because you don't know the genetic size of the parents?
Yes, and many times you may not even know the gestational age of the mom because she maybe didn't have prenatal care, shows up on our doorstep and we do an ultrasound. And let's say the measurement comes out that the patient's 32 weeks pregnant. Well, is she really 32 weeks pregnant? Or was she 36 weeks pregnant with a growth-restricted baby?
Okay.
So you kind of need 2 points. When we have a patient, we usually date them by their last menstrual period.
Okay.
And term pregnancy is considered 40 weeks from the first day of their last period.
Okay.
In a way, we kind of lie to patients because it's not the 9 months.
Not the typical 9 months we're all looking
Right,
forward
we're
to.
adding 2 weeks really to a pregnancy when we date a pregnancy. So because there's an error in ultrasound as well, let's say in the 3rd trimester there can be an error up to 10 to 14 days off. So we date a pregnancy at 32 weeks. The question is she 32 weeks or 36? So usually we'll repeat an ultrasound to find out, is the baby growing along its curve? And if that baby at 32 weeks and now you do it 2 weeks later is 34 weeks in measurements, that baby's growing pristine along its curve, and therefore the dating that was established, although late in pregnancy, is correct.
Okay.
But if we repeat the ultrasound and then the same patient who's 32 weeks and you do an ultrasound in 2 weeks and that fetus only grew, say, a week in size, we can suspect that more than likely that baby's having an element of growth restriction because it's not growing along what should be a normal fetal curve.
Okay, so let me make sure I understand then. When you do the ultrasound, you're taking multiple measurements during that ultrasound,
Correct.
and then you're also doing repeat measurements at different points in time?
Correct.
So if you don't have that initial measurement or that baseline, if you will, is it possible then to compare that measurement to anything?
No. You just have one measurement in time. You don't know if the dating is, it all depends too when you're in pregnancy, where you are in pregnancy. If you're in the 1st trimester and you do an ultrasound, you're within 5 days of when the patient's due date is calculated. So it's very accurate.
Okay.
But as you go further along in pregnancy, ultrasound is less accurate, but more so when you have more points in time to compare.
Okay. Let me ask you this. We've had a lot of discussion over the past few days about fundal height. Is fundal height an accurate measurement for intrauterine growth restriction?
No,
And why is that?
because it's a screening test.
Explain
And-
what you mean, doctor.
Well, screening tests are not diagnostic tests, and probably the best analogy to explain it is that when a woman goes in for a pap smear and the pap smear comes back abnormal, the odds are the patient doesn't have cancer. What the patient needs is a diagnostic test, i.e. a biopsy or whatever, to make that diagnosis. But more times than not, that screening test, the patient doesn't have cancer. So it's a false positive. Same thing with when you do a fundal height measurement, it's a screening test. And usually what we do, I've been taught in textbooks that it's the fundal height generally is quite accurate up until about 20 weeks. And particularly the further along you go, the more the error. But generally, if you do a fundal height and it's within 3 centimeters of how many weeks a patient should be, in other words, you measure this patient, the example I gave earlier is 32 weeks. Ideally, a normally growing fetus would measure a 32 centimeter fundal height measurement. But if the patient measured 29 weeks, i.e. smaller, or if the patient measured 35 weeks, 3 centimeters greater, that usually triggers an ultrasound because you don't really know, is it really accurate? You may have decreased fluid that can give you a small measurement. You may have a big baby that gives you a large measurement. And the only way to know is an ultrasound to accurately determine, based on the parameters I said, how far along the patient is and what percentile they are on the curve.
Doctor, what is, if you know the error rate in the 3rd trimester with fundal height measurement?
They're probably at least 60% wrong. Because as you get further along, and generally speaking, the majority of babies are born head down. You got the biggest part of the baby weighing the head down, the pelvis. And studies have shown that 60% of the time, after 30 weeks gestation particularly, your fundal height measurements are wrong.
Okay. Does that error rate increase if you use your hand to do the fundal height measurement as opposed to a tape measure?
Yes,
Or can it increase?
most definitely.
Now, doctor, I want to ask you about something you just said. At that point in time, the baby starts changing position in the third trimester, correct?
Correct.
And you made mention of the baby transcending into the pelvis. What do you mean by that?
Patients, the biggest part of the baby is the fetal head. So that's why most babies are born coming head first. And just by virtue of gravity, that babies during the advancing gestational age will get lower in the pelvis. So your fundal height measurement is going to go down with advancing gestational age. Whereas if it stayed in the same position, your fundal height would continue to grow. But as it drops, your fundal heights are not commensurate with advancing gestational age.
When you talk about the baby transcending into the pelvis, is that what's also known as cephalic presentation?
Cephalic presentation just refers to the fact that the baby is head down.
So let me ask you this, doctor. Based on the way you've described it to us then, in the absence of having those serial scans, your baseline, and then however many ultrasounds you determine you're going to do subsequent to that, is it possible, based on a fundal height measurement alone, to make a diagnosis of intrauterine growth restriction?
No.
Is it possible to make that diagnosis off of just a single measurement of a single bone?
No.
And I want to be clear, when we're talking about multiple measurements, you're not talking about doing like a hand palpitation fundal height measurement on one day and on that exact same day taking an ultrasound measurement of one bone. You're talking about multiple measurements over a period of time?
Yes.
Okay. So 2 measurements in one day are not what you're talking about when you're talking about serial or multiple measurements.
Correct.
Doctor, sticking with this diagnosis of intrauterine growth restriction, does a diagnosis of intrauterine growth restriction, if you in fact have it, result in stillbirth?
No. By far and away, the majority of growth-restricted babies still are born alive.
So such a diagnosis does not presume stillbirth?
No.
Have you, in the course of your career, dealt with growth-restricted babies?
Yes, every day.
And have they survived after birth?
Yes.
If you have an intrauterine growth-restricted baby upon birth, what do you do?
Well, if we have a diagnosis of in utero growth restriction and we're at term, we usually recommend induction of labor. And most commonly, the babies the mother's induced for growth restriction, and we have a favorable outcome. That's why
medical treatment and they survive?
Correct. We do fetal testing on those patients so as to prevent stillbirth in babies that are significantly growth restricted.
Doctor, as part of your current employment duties, you previously indicated that on occasion you are called upon to do consultations.
Yes.
In this case, State of Ohio versus Brooke Richardson, were you requested by the Warren County Prosecutor's Office to engage in a consultation regarding 2 issues, whether she had an intrauterine growth restricted fetus and whether or not her child may have been stillborn?
Yes.
And for purposes of your consultation, did you request and subsequently review materials associated with this case?
Yes.
Do you recall when we consulted with you, my office providing you with the coroner's report?
Yes.
Dr. Elizabeth Murray's anthropological report,
Yes.
Dr. Latham's anthropological report,
Yes.
the defendant's OBGYN records from Hilltop,
Yes.
the defendant's sports physical,
Yes.
records for her from her youth from Cincinnati Children's Medical Center records,
Yes.
records from Dr. Lori Dunham, also from her youth,
Yes.
records for the defendant from Cincinnati Center for Well-Being from her youth,
Yes.
Carlisle High School records,
Yes.
both police interviews of the defendant.
Yes.
And did you also receive both of the reports authored by Dr. White?
Yes.
Doctor, in the course of your examination and consultation on this case, were you able to make findings relevant to those two issues?
Yes.
I want to talk to you about the diagnosis of intrauterine growth restriction first. Based on the evidence that was presented in this case and your assessment of all of that evidence, all of the medical records, the interviews, everything that had been provided to you, was there sufficient evidence to support a diagnosis of intrauterine growth restriction?
No.
You just talked to the ladies and gentlemen of the jury about the fundal height measurement.
Yes.
Are you aware that in this case, there was only one measurement ever taken of baby Richardson, and that was on April 26th?
Yes.
And that was a fundal height measurement obtained by Dr. Andrew with his hand, and one ultrasound measurement?
Objection. It's not a proper question.
I will sustain the objections to the form of the question.
Doctor, are you aware that there was a fundal height measurement obtained by Dr. Andrew?
Yes.
And are you aware that there was a preliminary ultrasound also performed on that same date?
Yes.
And that those both took place on April 26th?
Of 2017, yes.
Based on what you just explained to the ladies and gentlemen of the jury, based on that one fundal height measurement and that one ultrasound measurement, why can you not make a diagnosis of intrauterine growth restriction in this case?
Because it's only one point in time. And so you just presume based on whatever fundal height measurement you come up with, that's your guess as far as the gestational age. In order to make a diagnosis of IUGR, i.e. the baby's not growing, you have to have 2 points in time, whether it be an ultrasound or in your screening test, a drop-off in fundal height on 2 different visits, probably at least 2 weeks apart.
And was there ever a second measurement obtained to your knowledge so that the April 26th measurement could be used as a baseline?
Not my review of the records.
Are you aware that in that fundal height measurement obtained on that date, that Dr. Andrew estimated baby Richardson to be approximately 32 weeks?
Yes.
I know we didn't know the 2,500 grams, but when you're talking about third trimester at 32 weeks, are we now into the third trimester?
Yes, the third trimester starts at 28 weeks gestation.
So by approximately 4 weeks into that, give or take, are we now in that 60% error rate?
Yes.
And if Dr. Andrew indicated that he did the fundal height measurement with his hands, does that error rate now increase?
Yes.
Did you you said that you had an opportunity to review the Hilltop records for the defendant?
Yes.
Are you aware that in these records it indicates that baby Richardson on April 26th was in cephalic presentation?
Yes.
How does that affect the fundal height measurement of 32 weeks?
Probably makes it more inaccurate because the baby's going to be lower in the pelvis.
And if the baby's lower in the pelvis, does that mean that the 32 weeks may in fact be greater?
Yes.
Doctor, in any of the records, is there any indication of the date of conception?
No.
So without having a date of conception, the only thing we have is that one measurement to estimate the timing or the age of this child?
Correct.
And you have nothing to compare that against?
Correct.
Doctor, if all we have is that fundal height measurement at roughly 32 weeks, we have a baby encephalic presentation, which means we can have, even though it's a screening tool, up to a 3-week offset, taking that baby up to 35 weeks. If she is then born approximately 2 weeks later at 37 weeks, is that considered a significant lag in her growth?
No.
If she is not larger than 6 pounds, and to be fair, there's nothing in any of these records to indicate what this child's birth weight is.
Correct.
So when we talk about the size of this child, we're dependent upon whatever information we get from the defendant, correct?
Correct.
Okay. So when we talk about a growth lag of 2 centimeters or 5 centimeters, because we've heard references throughout this case already that this baby was probably closer at the time that Dr. Andrew measured her to 35 or 36 or 37 weeks. In fact, she could have measured at that point on April 26th if the appropriate testing had been done, correct?
Correct.
And so if she is then born approximately 2 weeks after that April 26th appointment, do we really have a lag in growth?
No.
Doctor, can a diagnosis of intrauterine growth restriction be made off of the weight gain of the mother?
No.
Why not?
Because different patients put on different amounts of weight. And in terms of recommended weight, the recommended weight gain during a pregnancy is within even a 10-pound range as far as by most authorities. So there are patients that put on 55 pounds and there's patients that put on 15 pounds. But just because they don't put on as much weight or they put on more weight does not correlate with fetal size.
Okay. Would you also have to have accurate information as to what the mother's weight was when she conceived to know how much weight had been gained during the course of the pregnancy?
Yes.
And are you aware that in this case, there is no weight measurement in any of the information that we have for the defendant in the month of August of 2016?
Correct.
So we don't know what the defendant's starting weight was when she conceived her daughter, would that be correct?
That is correct.
Are you aware from your review of the records that the defendant had an eating disorder?
Yes.
How does that factor in to her weight during her pregnancy?
It may have affected her weight gain. We don't know. Unfortunately, we don't have any points in time other than the one on 426, which she weighed at that time. And if I recall, it was around 147 pounds.
147 pounds in April of 2016, or I'm sorry, 2017?
I believe.
Okay. In your experience, individuals that have an eating disorder, does their weight fluctuate?
Yes.
Do you have any information in this case provided by the defendant or otherwise as to what her weight was in September of 2016?
No, no idea.
October of 2016?
No idea.
November of 2016?
No idea.
All the way up until the first weight we get is in April.
Correct.
Do you have any information as to when she first started showing? Her belly started protruding a little bit.
No.
Do you know or have any information that when her belly started protruding and you factor in her eating disorder, if she took any steps to try and decrease her weight gain at that time?
No idea.
So you have no information about what her weight was when she conceived or what her weight was for any of the 9 months plus 2 weeks following?
Correct.
You don't know if her weight went up, down, stayed the same,
Correct.
anything?
Correct.
And you said a weight gain of only 15 pounds. Again, that's not diagnostic of intrauterine growth restriction?
No.
Doctor, when you reviewed the Hilltop medical records, were you aware that blood work had been done on that date?
Yes.
Tell me this, when an individual is pregnant, the food that we consume, the nutrients that we consume, everything that is coming into our body, is that going first to the mother or first to the child?
First to the mother, digested, converted into nutrition within the bloodstream, which then passes the placenta to the fetus.
And mom gets what's left over?
Correct.
Your Honor, may I approach?
You may.
Doctor, I'm showing you the defendant's blood work for April 26th of 2017.
Okay.
Is there anything in her blood work to indicate that her nutritional status was anything other than within the normal range?
No. And the first thing we look at is, for those of you that go to your doctor and they do a blood count, what we're really measuring is the hemoglobin and hematocrit. And the hemoglobin is 12.1 grams per deciliter, and the hematocrit here was 36.1%, both of which are in normal limits. And if there was a nutritional issue, one of the first things usually to go down on your blood is your blood count or your hemoglobin. And I'm sure you've all heard of anemia. Some people might have trouble absorbing iron if they're taking supplements, but most commonly if you have any nutritional issues going on, you're going to reflect it, and it's going to manifest as anemia on your blood count.
And is there any indication on her April 26, 2017 blood work that she is anemic?
No,
Even close to it?
no, completely normal range.
Doctor, you're aware that an ultrasound was also performed at that appointment?
Yes,
By the time that the baby reaches 32 weeks, plus or minus, because all we have is that fundal height measurement to go off of, would you expect, because you've talked a little bit on growth restricted babies about how we see a difference in their head to abdomen ratio, correct?
correct.
By 32 weeks, would you expect that to be visible on an ultrasound?
Yes. Because we do when we do ultrasound measurements through the body or the trunk, we're doing cross sections. So it's like taking a tree and chopping it off at the stump and looking down on that stump. And so if you've looked at the baby's head and you've come down and done a cut through the abdomen, you will see a discrepancy, the head being larger than the abdomen, if indeed you have growth restriction, just by a gestalt look without actually doing measurements if there's significant IUGR to the extent that would cause fetal death. And again, babies are parasites. They take what they need at mom's expense in terms of growth.
Some of these babies that are also intrauterine growth restricted and are at risk of fatality, do they tend to have some dysmorphic features?
They can, yes.
And is that something that would also be evident on an ultrasound?
Yes, assuming the person performing the ultrasound has done ultrasound. But most OBGYNs have ultrasound training during the course of their residency. In fact, it's required.
Thank you, doctor. At 32 weeks, plus or minus, or up to 35 weeks, would you also expect on an ultrasound to see evidence of a decrease in amniotic fluid?
Yes,
You are aware that in this case, when Dr. Andrew performed the ultrasound, he indicated that the baby had a fetal heart rate of 140.
yes.
What does that indicate to you, doctor?
That's a normal heart rate. Fetuses in the third trimester, or after 20 weeks really, have a heart rate between 120 and 160. And it varies. It varies in relative to baby's movements. When baby moves, the heart rate goes up just like you or I running down the hall. And that's a good physiologic response. So the next time you measure baby's heartbeat and it's 150, it's in the normal range. It just depends on what the baby was doing just before you measured the heart rate.
So doctor, when we have this ultrasound and there's anywhere from 32 to 35 weeks, no indication that we have a growth-restricted baby, no indication of any inequality between the head to abdomen ratio, no indication of low fluids, and we have a solid heart rate of 140, what does that indicate?
Generally means the baby is healthy.
And if we have a healthy baby on April 26th of 2017, would you expect to have a significant change in the outcome of that child in 1.5 weeks?
Yes. I would expect the baby to still be alive.
Still be alive?
Yes.
Thank you, doctor. When you look at everything that's been provided to you and everything that we've just discussed, is there anything in these records or anything in the defendant's statement to indicate this was an intrauterine growth-restricted baby?
Not that I could glean from the records.
Let's talk a little bit more about stillbirth. There have been a lot of questions posed of some of the other doctors in this case about the condition of baby Richardson at birth. The defendant indicated in her interview that she doesn't know whether the cord was attached or not. What, if anything, does that mean to you?
It means absolutely nothing, because the definition of a live birth in the state of Ohio is a baby born after 20 weeks gestation, whether the cord's attached or the baby's attached to the cord's attached to the placenta, makes no difference. The baby has movement, respiratory effort, and a heartbeat. Doesn't matter whether the cord's attached or not, that's a live born.
There's been discussion about there might not have been a lot of amniotic fluid because she doesn't know if her water broke or not. What does that mean to you, doctor?
We have women coming into our triage unit daily that question whether their water's broke. We have patients come in bleeding that just present with bleeding and come to find out part of them, their water was broke, mixed with a little blood. It doesn't take much blood, for example, to turn the toilet red. Just a few drops in the toilet turns it red. So you could assume you could have blood, when indeed it's amniotic fluid, or just all blood. So it's often difficult to tell as a patient, particularly if somebody has never delivered before, whether they've lost their fluid, just bloody show, whatever.
And is it, if a female while she's pregnant has a little bit of blood or what have you, does that mean that the baby's going to be stillborn?
No.
Is it typical for women to spot during their pregnancy?
Yes.
What are
Up to
some
20% of patients will have spotting during the course of their pregnancy, or 1 in 5.
And for what reasons?
It can be just cervical irritation. The cervix, during the course of pregnancy, hormonal change, the cells on the cervix migrate to the outside of the cervix. It's kind of like, when you look at a cervix, it's like a raw scraped knee. So if a woman's been doing a bunch of housework, bending over, whatever, just scraping that cervix against the vaginal wall can lead to bleeding. So there's many causes of bleeding. Cervical dilation can cause bleeding.
Can vigorous exercise cause bleeding?
Yes.
Doctor, you said you had an opportunity to also look at both of her interviews?
Yes.
You're aware that prior to her daughter's birth and subsequent to her appointment, she had indicated that she could feel the baby moving inside of her.
Yes.
Does a dead baby move?
No.
You're aware that the only person that has knowledge as to the size of baby Richardson is the defendant, correct?
Yes. And when we look at fetal movement, we put all our patients on what we call fetal chart movement.
It's not in response to a question.
Also state the objection. Ask your next question.
Doctor, I asked you if a dead baby can move inside of the mother, and you said no.
No.
Can you explain?
Babies are no different than adults. If an adult drops dead on the floor of a heart attack, they're not going to move. A baby in utero that's not alive is not going to move. Now, if you jumped up and down, you might, depending on where you are in gestation, you might feel it. But other than that, no.
So if the defendant, by her own statement, is indicating that she's feeling movement within inside of her, that is indicative of a live fetus?
Yes.
I was starting to ask you, are you aware that the only person that has ever laid eyes on baby Richardson is the defendant?
Yes.
And so she's the only one that knows what baby Richardson looked like when she was born.
Correct.
Were you also aware from reviewing her records that she worked at Child Watch?
Yes.
And that was a daycare at the YMCA, and that she worked with infants as young as 6 weeks of age.
Yes.
So she had some knowledge of babies.
Yes.
Are you aware that in her interview, she described baby Richardson as she was kind of big?
Yes.
She didn't say she was kind of small, she said she was kind of big.
Yes.
Is that indicative of a small baby or a particularly tiny baby?
I presume she's seen different sized babies and she would know the difference.
Thank you. When you reviewed her transcripts, are you aware that she indicated to the investigators when questioned, was she moving at all, a little kick or anything, and she said maybe?
Yes.
Were you aware that when interviewed by the investigators, she said that she thinks she made a noise
Yes.
and that she made a gurgle
Yes.
and that she moved
Yes.
and that her arms in particular were moving?
Yes.
Are you aware that when they questioned her about how long her daughter was alive, she said 5 minutes?
Yes.
Are you aware that throughout her interview she talked about squeezing her daughter?
Yes.
And are you aware that when they questioned her about the timing of the squeezing versus the crying of her daughter, she said that she was crying before she squeezed her? Just a little crying, just a little crying.
Yes.
Doctor, in your experience, babies that cry and gurgle and move their limbs, are those dead babies?
No.
Are those signs of life,
Yes.
not indicative of a stillbirth?
Not indicative of stillbirth.
Doctor, in this case, were you given the reports from the doctor that the defense retained, Dr. John White?
Yes.
And are you familiar with Dr. John White?
Yes.
How do you know him?
He's a general obstetrician gynecologist at the Christ Hospital, or practices out of the Christ Hospital.
Okay. He's not a maternal fetal specialist, correct?
Correct.
When he has a high-risk pregnancy or a high-risk baby, does he consult with you? With your
Yes.
practice?
Yes.
Your Honor, may I approach?
You may.
I'm showing you two reports authored by Dr. White. You've seen those before and had the opportunity to review them?
Yes.
When you are involved in a case, if you're presented with information or an opinion that's different from yours, are you willing to take it into consideration?
Yes, I'll take it into consideration.
When you read those reports, did anything that Dr. White put in his reports change your opinion on this case?
No.
You're aware that he has made a diagnosis of both intrauterine growth restriction and stillbirth?
Yes.
I'd like to go through those reports with you, if you will, starting with the February 7th report. Dr. White starts out by indicating that Ms. Richardson delivered a term female infant approximately 39 weeks.
Correct.
Do you agree with that?
Yes.
And that this was based on a femur length.
Yes.
That is the femur length, if you're aware, that was obtained by the anthropologist post-mortem. Is that correct?
That is correct.
There was never a femur length done in this case, was there?
No.
He indicates in his second point that based on that 39-week guess as to the age of baby Richardson, that Miss Richardson's likely conception date was around August 21st of 2016. Do you agree, based on your review of the records, that that is at least consistent with the timing of the relationship that she had with the baby's father?
Yes.
In his next point, he goes on to say that the pregnancy was likely complicated by intrauterine growth restriction. Would you agree?
Could you restate your question again, please?
In his third point, he goes on to indicate that he believes Miss Richardson's pregnancy was likely complicated by intrauterine growth restriction.
That's what he states.
And he says this is based on a fundal height measurement of 32 weeks, correct?
Correct.
And based on that 32-week measurement and the fact that she had a baby a week and a half later, that there is, in fact, a 5-week leg in growth for baby Richardson.
That's what he says, yes.
Do you agree with that?
No.
Why not?
Because of the inaccuracy of fundal height measurements after 30 weeks particularly.
So if we go back to our original questions, if that 32-week fundal height measurement, which was done by hand, is inaccurate by 3 centimeters, and baby Richardson was in fact 35 weeks, and then born approximately 1.5 weeks to 2 weeks later, we're now up to almost 37 weeks, correct?
Correct.
Objection. Improper question.
At that point, if a baby is born at approximately 37 weeks, would that be considered close to full term?
Yes.
Is that a 5-week leg then?
No.
He does not mention anywhere in there when discussing the 32-week fundal height that baby Richardson was already in cephalic presentation, does he?
No.
But that information was contained in her obstetrical report.
Correct.
He then goes on to talk about her weight gain. And he uses a sports physical done in July of 2016 in which she was 134 pounds, compares that to her weight on April 26th and definitively says she only had a 15-pound weight gain. Is there any way, without knowing how much she weighed on the date she conceived and how much she weighed at every other month from that date until the baby's birth, what her weight gain is?
No, there's no documentation of weight at all.
And again, this is an individual that has an eating disorder,
Correct.
and there's no indication in here of whether her weight was going up or down or what she was doing during that period of time, is there?
That is correct.
You've said that we can't make a diagnosis of intrauterine growth restriction off of the mother's weight,
Correct.
but can we even assume that this 15-pound weight gain that he identifies in his report is accurate?
No.
Does he mention anywhere in here or make any reference to her blood work and how she was within normal range on every measurement in her blood work?
No.
From that, he goes on to say there's a significant likelihood that Miss Richardson delivered a stillbirth. So that's based on this 32-week fundal height that he is definitive about, a 5-week leg that he is definitive about, and her 15-pound weight gain that he is definitive about. Is that correct?
That's correct.
In any of the records that have been presented, is there any indication, and he talks about the reason that we're at risk of having a stillbirth here is because there was no gush or apparent leakage of fluid. Is there anything in here to indicate that there was a gush or was not a gush?
No.
Is there anything in these records or noted by Dr. Andrew to give any indication of whether or not there were any dysmorphic features on ultrasound or whether the head to abdomen ratio was in line with what it should be?
No.
He talks about the cord. So let's talk about that a little bit. He accepts her statement that the cord was not attached when the baby came out.
Correct.
And I think you've touched on this already, but the cord not being attached, is that diagnostic of a stillbirth?
No.
Okay. Talk to us about the cord. What does it do?
The umbilical cord delivers nutrition, oxygen from the placenta to the fetus.
She doesn't know if it's attached or not. She makes references to it being attached. She makes references to it not being attached, but she doesn't know if it was attached. And then she also makes references that it wasn't attached, correct?
Correct.
If the baby comes out, for sake of argument, without the cord being attached to the placenta, does that give you any indication as to the timing of when it could have detached?
No.
How long is the umbilical cord?
It's about 55 centimeters. There's 2.2 centimeters in an inch, so it's around 25 inches.
Okay. One end attached to mom and one end attached to the baby. The end that is attached to mom, describe how the cord attaches to the mother.
Well, it attaches to the placenta, and the placenta thereby attaches to the uterine wall. So if you think of the placenta as being around, about the size of between a dinner plate and a small salad plate, that part being attached, the umbilical cord is then, the placenta is attached to the uterine wall, then the umbilical cord is attached to the middle of the placenta generally, that then goes to the baby at the side of your umbilicus, or your belly button.
Okay. Is it easier to cut the cord, or is it easier for the cord to break away from the placenta?
It's much easier to cut the cord
How so?
because you're using sharp scissors.
Okay.
The cord has a gel, and it's sort of like you can tether and stretch it. Because when we actually do a delivery, one of the first things we do, when we clamp the cord, we stretch the cord so we have a distance or whatever, so we can cut the cord. And nowadays we're sending cord segments on all babies to the lab for drug screens.
Okay. Let's assume, because we don't know, but let's assume the cord was not cut. Is it possible for it to break away from the placenta?
It's possible, yes.
How so?
Well, if you delivered, say, in a standing up position or even from a bed, and say the baby were to drop to the floor, you only got like 25 inches from within mom to the floor. It could easily, or depend on the weight of the baby, I should say.
Can the weight of the baby break the cord?
Correct.
Now, I know that most situations that we're familiar with, you're in the hospital, correct?
Yes.
Mother's laying in a bed and you're helping to bring the baby out
Yes.
into the world. And so the cord comes out with the baby. There's really not the pressure or the weight of the baby pulling that cord, correct?
Correct.
If you're not in that situation and you said you're in a standing or seated position and the baby is actually dropping out of you and there's nothing to catch or no one to catch or Dr. Brady's not at the other end to help bring that baby out, is that what you're talking about, that when the baby drops out, the weight of the baby can pull on that cord?
Yes.
And in that circumstance, can the weight of the baby break the cord?
Yes.
Does that mean that the cord was broken prior to?
No.
Are you aware that there's no indication in any of these records that there was anyone to catch the baby, that she fell out of the defendant?
That's my understanding.
And if you're seated and there is a distance from you to the floor of 25 inches, would that be enough distance?
Yes.
What if you are holding on to something and bent over and the baby drops out of you to the floor? Would that be enough distance and weight from the baby to break the cord?
Yes.
What if when the baby drops out, you pick the baby up while it's still attached? Could the motion of bringing that baby upwards towards you avulse or sever the cord?
It could, yes.
So the fact that the cord may or may not have been attached at the time baby Richardson finally came out of her mother, can you attach any significance to that?
No.
In her interview, and Dr. White makes reference to it, when asked about the color of her child, Ms. Richardson indicated that she was white. What significance do you attach to that, doctor?
None.
And why is that?
Some babies come out blue, some come out pale, some come out pink. But they can all have normal heart rates. So I don't attach much significance at all to it.
In your career, have you had the experience of delivering a stillborn child?
Yes, unfortunately,
Many times?
many times.
And typically, what color are they?
White, pale, gray, depends how long they've been dead in utero.
Does the color of the baby alone at the time of birth give you any indication that this was a stillborn child?
No.
Dr. White goes on to talk about the likelihood of this being an IUGR baby and that there was a fetal death is made more significant due to the short period of time that Miss Richardson was in labor. Does the duration of labor indicate that this was a stillborn baby?
No,
Are you aware from your review of all the materials in this case and the defendant's own statement that she was cramping and having significant back pain and knew that that's what was happening throughout the entire day leading up until the birth of her daughter?
Could you repeat the question again, please?
Are you aware from a review of her statements in the transcripts that she told the detectives that she was having a lot of pain in her back, sharp pains, that was going on throughout the entire day leading up until that night when she had her daughter?
Yes,
That at points she was laying on a heating pad trying to help with the pain that she was experiencing,
yes,
and that she knew what was happening?
yes,
If a mother labors all day long and into the night having the baby at approximately 3 a.m., is that considered a short labor?
no. It's pretty typical labor.
Dr. White then concludes his first report by talking about this mammalian dive reflex, and that any gurgling sounds that might have been heard were by virtue of the baby being born into the toilet. Do you agree with that, doctor?
No,
And why is
Overruled.
that?
you shouldn't hear any gurgling out of a stillborn.
Can dead babies gurgle?
No,
On March 28th, we have a second report from Dr. White, correct?
yes,
And at this point in time, there's no more, it's indicative of, it suggests that now he definitively says we have IUGR and we have a stillbirth, correct?
correct.
Ms. Kraft, I apologize for interrupting your examination. I think it probably makes sense for us to go ahead and take a break at this point. Ladies and gentlemen, we are going to take our afternoon break. Remember what I have previously told you. Do not begin to think about how this case should come out or talk about the case amongst yourselves. We will plan on being back here at about 10 after 3. Mr. Mullins, you can take the jury out. Counsel, approach, please.